All right. Hi everyone. Thanks for coming today. So we have Anisha here to present, and Dr. Batara should be joining us sometime throughout the presentation. So I will hand the reins over to you, Anisha. And if anyone needs or has questions or anything, feel free to put in the chat or just unmute your mic, okay? All right, take it away, Anisha.
Perfect. So like Sam was saying, if you guys have anything to add or like want to make any comments or anything, please just like unmute yourself and go for it. This can be super casual. I don't want it to be like I'm presenting. I don't know. I know I'm presenting, but I don't want it to be so like formal. But anyway, so if you don't know me, my name's Anisha. I'm a third year medical student at UMHS. You could go to the next slide. And basically today I picked this article that I thought was interesting to discuss breast cancer disparities and outcomes in underserved women. So basically the article reviews and examines breast cancer disparities for minorities and underserved women in the US, as well as offering strategies on how to mitigate these disparities. So yeah, that's just kind of a quick overview, but to get started, breast cancer accounts for 1/3 of all incident cancer cases in women. And since 1989, the mortality rate has been reduced by 42%, which can be attributed to increased awareness, as well as mammogram screening and treatment also. But underserved populations of women in the US do not typically experience these reductions. They just continue to face disparities in breast cancer outcomes. So these are driven by race and ethnicity and socioeconomic factors, which can include low income, low education levels, inadequate health literacy, being uninsured or underinsured, and living in rural areas. And data has shown that this can contribute to 80%, upwards to 80% of disparities in vulnerable or at-risk populations. And additionally, uninsured patients are treated within safety net healthcare systems, which are institutions that provide healthcare to patients regardless of their ability to pay. So because of this, there's typically a lot of difficulty with access to breast cancer screening, and there's less opportunity to be able to undergo supplemental imaging when needed. And all of this contributes to delays in diagnosis and treatment, thus causing much higher stages during diagnosis, as well as treatment just starting later, which we all know is not good if you have cancer. And then later on, like I said earlier, we'll kind of discuss some of the ways that the authors of this article kind of tried to mitigate those disparities. So on the next slide, we're looking at race and ethnicity, race and ethnic impacts of breast cancer outcomes and the roles they play. So this is looking at incidence and mortality in different race and ethnic groups. And this is taken from the National Cancer Institute. The data is from 2015 to 2019. So it's not like super, super new, but it's fairly recent. So orange is showing incidence rate and blue is showing mortality rate. And so something that was interesting to point out is that breast cancer rates are highest in non-Hispanic white women, followed by non-Hispanic Black women, and then are lowest in Hispanic women. However, Black women are more likely to die of disease than are non-Hispanic white women, despite the lower incidence rate. And so specifically, this study was showing that there was a 5.8% lower incidence rate of breast cancer in Black women, but a 40.7% higher breast cancer mortality rate. So on the next slide, now we're looking at stage at time of diagnosis. So Black women are in orange, and here it's showing that they have higher rates of regionally advanced and distant breast cancer stage during the time of diagnosis when compared to any other race or ethnicity. And this is closely followed by Hispanic women shown in green, who have the second highest percentage of regional disease, and the second lowest percentage of localized breast cancer at the time of diagnosis. So yeah, so that's kind of just what's seen there. Could go to the next, perfect. So one of the biggest things the article focused on was how breast cancer has a disproportionate impact on young Black women, especially from ages 15 to 39, compared with any other race or ethnicity, and they're more likely to die of breast cancer at every age. The greatest difference in breast cancer incidence and mortality rates between Black and non-Hispanic white women was greatest in those who were 50 or younger. And then as they got older, it kind of diminishes over time. And the higher incidence and mortality rates that are seen among Black women between ages 20 to 39 could be explained by a higher incidence of triple negative breast cancers, which have poorer prognosis. And triple negative is ER, PR, and HER2 negative breast cancer. And then also Black women are often diagnosed with hormone receptor negative cancers. And these typically manifest as clinically palpable cancers rather than being seen on imaging or mammograms and stuff like that. So further, they mentioned a Black women's health study that found that in disadvantaged neighborhoods and lower neighborhood level socioeconomic status, there was an approximately 25% increased risk of estrogen receptor negative breast cancer. So besides incidence and mortality, there's also disparities within screening. So in Black, non-Hispanic, American Indian, Alaska Native, and Hispanic women all exhibit lower rates of screening utilization compared to those of non-Hispanic white women. And Black and Hispanic women are less likely to have supplemental screening, breast ultrasounds ordered and completed. And also they're more likely to lack follow-up and experience delays in follow-up imaging compared to white women. And in another study, it was reported that Black women are more likely to experience delays in treatment regardless of their socioeconomic status, which I found to be interesting. And they said that they're and then they mentioned how delays in treatment as short as 30 days can affect breast cancer prognosis, which makes sense because the longer you wait, the more it's going to grow, which we all know. And Black women were also seen to have prolonged treatment duration, but they mentioned that this could just be due to the higher rate of hormone receptor negative breast cancers. And lastly, genetic factors. We all know BRCA1 and BRCA2. So these genes are typically seen in only 1 in 400 people. However, it is much more frequent in Black and Hispanic patients with breast cancer. So, oh, sorry.
Sorry, I had a kind of question / comment.
Yeah.
The screening utilization, did they go into details specifically on what they looked at, or was that just more of like an assumption of like, lack of access and stuff like that?
I think it was like lack of access. And then later they kind of bring up about how sometimes clinicians are like vary in what they order or like recommend for their patients. So I feel like it's a little bit of both. There's probably like a bunch. I mean, we'll get into like the social determinants of health, which I think is like another big reason why there's less utilization.
Yeah, essentially it will answer my question. All right,
Yes.
thanks.
Hopefully, if not, I'll try again. So the gender minority population are another group who often experience social disadvantages and discrimination, leading to inequitable healthcare and unfavorable outcomes in cancer care. But unfortunately, data is pretty variable, showing like lower rates in some studies, higher rates in others for screening compliance when compared to patients who identify as heterosexual. So something that I added, which I thought was really interesting, was the American College of Radiology basically released this like appropriateness criteria for breast cancer screening in transgender individuals. So they use like expert opinion and evidence. So I just picked a couple of interesting ones to just kind of look at. So on the next slide, there's two more ones, but yeah, so like for the top one, it's basically saying like if you had a bilateral mastectomy, if you're transitioning from female to male, that you don't actually need any screening, which makes sense because all your breast tissue has probably been removed. But overall, there's a lack of definitive data and longitudinal studies to evaluate the effectiveness of breast cancer screening, specifically in the transgender population. So it's just another area that needs more focused breast cancer research. So on the next slide, rural populations are obviously another big breast cancer disparity group. And there was a study that reported there was a lower incidence rate of breast cancer in rural areas, while others have have revealed no significant differences between rural and urban mortality rates and stage of diagnosis. So again, like similar to the last slide, it's pretty variable, but it's probably due to lower screening rates because of because there's less availability of screening, or people have to travel much further to be able to get them done. All right, so this is like kind of the last of all of these facts and stuff. So social determinants of health contribute to disparities and barriers that many of the women face. And social determinants of health are described as any non-medical factors that contribute to these disparities. So one of the big things that was mentioned was how education and income gaps were cited in the 2013 National Research Council report as the leading cause for health disparities within the US. And so in a study that looked at relationships between race, education level, and mortality rates from breast cancer, revealed that mortality rates were higher among women with lower level of education compared to women with a higher level of education. Additionally, those without health insurance or are considered of a lower socioeconomic status are another two big barriers that can result in lower screening mammograms, as well as utilization of supplemental imaging in these vulnerable populations. And then kind of like I was mentioning earlier, there's evidence that clinicians often differ on what they order for their patients based on their socioeconomic status, kind of showing that like women with higher socioeconomic status are recommended or ordered supplemental imaging more often than those of lower socioeconomic status. And there were other studies basically showing how racial and ethnic differences in higher stage breast cancer diagnosis were because of health insurance coverage. So kind of just, yeah, all of those are big important things. And then another thing that can affect women is housing instability, women who are homeless or unemployed, and again, can result in significant delays in treatment. And their evidence kind of shows that patients who are homeless experience a minimum 30-day delay in treatment and are often diagnosed with much higher stages of breast cancer. And kind of like we've been talking, low income and vulnerable populations, such as women who are homeless, they're less likely to receive screening mammograms, and they often encounter decreased access to care. They usually have lower health literacy, lack of health insurance, transportation is usually difficult, and they often don't have phones or mailing addresses, so it's hard to communicate with these patients and make sure that they're going to their follow-ups and their cancer is being followed and treated. And another group that I know that I've never really thought about were women who are incarcerated. And so they're especially vulnerable since they're often unable to advocate for themselves, because it kind of depends on the state, but basically if you're in prison, they can control your healthcare, who you're seeing, what you're getting. So it really just depends on where you are and what you might be able to have access to. Something that they did mention was that cancer is the leading cause of death in incarcerated patients who are over the age of 45, and there's a twofold increased incidence of all cancers compared to the general population. But they did find that women often like were interested in being screened. So there was a survey that asked incarcerated women in a San Francisco prison if they were willing to undergo mammogram screening. And 88% of them reported that they would be willing to, but only 41% actually had opportunities to be able to undergo screening. And lastly, lack of transportation and childcare are two other big factors to think about in terms of being able to like go to appointments and get their screening and stuff done. And another group are patients who go to the emergency department rather than outpatient primary care offices. And these patients are pretty often lost to follow-up. So basically, social determinants of health like education, employment, income level, insurance status, housing stability, transportation can all influence the patient's access to care, and extremely important to consider since delays are obviously going to just worsen the outcome or make it much harder to treat. So before we go into like what the authors did to kind of mitigate these disparities, I just wanted to like open it up and see if anyone has anything, any ideas or anything they want to bring up about ways you think you could, like, I don't know, ways to help reduce or increase access to care for these populations or anything like that.
So, one thing we actually did on St. Kitts, Anisha, I don't know if you ever did this when you were on the island, but they would have like those health fairs, the free health fairs. And I think it was for World Cancer Day where we did like kind of like an info session or something at the hospital there. But anyways, things like that to like educate the community on, you know, how to do a self breast exam or like, you know, the examples I mentioned, we did other things too, like looking for skin cancer and blah, 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 all that kind of stuff.
Right.
But yeah, stuff like that, like educating community can definitely like be something directly that we can do to like impact our communities, you know? And it's kind of like easy for us to do when we're on the island because
There's a lot of need there because
exactly, yeah. Those tend to be these exact populations that like they don't have access or like we know like we don't even want to go to the hospitals there because it's so expensive and like kind of scary and like so imagine what their population thinks. So they probably just like kind of like put a wall up and ignore these kind of things. So yeah, education is like definitely like one of the things that can be directly like impactful.
no, for sure. And like, we didn't do the cancer one on the island, but because we care, I believe Ifani was like actually the one who planned it all. We did a diabetes like clinic, so not necessarily like cancer screening, but it was like outside of a church. So like after the services, like people would come through and we would do like weight checks and blood sugar and blood pressure and different things like that to kind of like get people at least interested or like to know, because obviously I don't know, like something that I feel like is super common is that you can have high blood pressure and not know it, and then you just think you're fine, and then like I feel like that's like every patient that comes in to the ED is like has no idea, or like they're seeing their primary care doctor and they are like, no, I feel fine, like I don't have high blood pressure or something like that. So yeah, those outreach events are definitely, I feel like, a big important way to kind of reduce these disparities. But we can go into what the authors did.
Anyone else
Oh,
have?
Anisha.
Oh, sorry.
Sorry. I
No,
was just waiting for you guys to finish. I didn't want to like cut you off.
no.
Because I know like there have been some studies too that have come out about how with like Black women, a lot of times like their pain is underreported, and it's not necessarily that women are not saying it, it's that their providers are not taking it seriously. And so like, you know, there's this big push with us as medical providers is to take everything that anyone is saying to you seriously. And that can be like I was thinking about like that can be really difficult for us because there's like so many, like if someone comes in with like a single complaint, there's so many things that can be, and in medical school we're taught to kind of like start eliminating the things that are like less likely. And especially with like, I don't know if you guys have noticed, I think there was a like a WHO article or something came out, or CDC posted something recently about how there's been like a higher incidence of cancer in younger people. So I think it's like really important for us as we are like going into our medical careers that like we need to keep that in mind, that like a lot of us have in our minds that like, oh, cancer is affecting older people, but there's like so many younger people now that are getting cancer, so we have to like start taking those things seriously. And then specifically with people who are coming from these underserved areas, like you were saying, a lot of them haven't had regular screening exams. So like things where like with pain or with issues, they might have been living with it for so long that in their minds it's normal. So it's really up to us to kind of like push them a little bit more to like ask them about those things and be like, hey, like that's not normal. Let's do something about it. Because
Right.
like they may not offer it up because they think it's normal. And even like I thought it was interesting. I think ACOG recently said that like, you know, the self breast exams, they actually don't recommend doing them anymore because a lot of people like basically get false like
Mhm.
results because they'll feel something and it's really just like fibrocystic changes. But,
Right.
you know, in groups that are underrepresented like that, you know, you may want to still implement that for them.
No, I totally agree. I feel like I have been hearing about that too, how like breast exams aren't really like recommended anymore, but I totally agree with you that like in these populations, it's probably still helpful for them to at least know and be aware. And then also kind of like going off what you were saying with, I feel like how you were saying like people like don't take maybe Black women seriously when they talk about their pain. So I feel like there's just so much distrust, and like I totally get it. I mean, like I wouldn't want to trust healthcare providers either if that was me. But if Ani, are you raising your hand to say something or?
Yeah.
Okay.
Just to bounce off of what Ananya said. I recently had my last preceptorship, and one of the doctors was telling me about how there was this one patient who, it's not her patient, but she was talking about a patient who was complaining about her behind her butt and how something doesn't feel right, and how she kept wanting to get screenings for cancer, but she was a 30-year-old woman, is a 30-year-old woman. So the doctors kept dismissing that. And she was also Black. She was complaining about all these things, but they were just like, no, it's probably not a big deal. Uh, Eventually, she went somewhere else, switched her PCP, got checked, and she did have cancer. And I
Well,
guess that's just me bouncing off of how a lot of physicians just need to listen to their patients.
for sure.
And if there's that much concern, then why not put it down? I know maybe insurance has something to do with it, or maybe it is just like sticking to the statistics and the age cutoffs for certain exams, but listening to your patient goes a long way. Yeah,
I
that's
totally,
it.
yeah, no, I mean, that's like, it's feels so like ridiculous to think that that's how it is. And like, I've been in my internal med rotation for like 5 weeks now. And I feel like exactly what Ifani's saying is like, you just, your patient knows themselves better than anyone. Like, so I feel like it's super important to trust anything that they're saying. Obviously, you know, there are like caveats to that, but for the most part, I feel like if your patient's saying something, it's probably because they know that something's wrong with themselves and this isn't normal, but it's unfortunate that that's not the way that everyone in medicine sees things.
Yeah, I mean, looking at things from the other way, from the other side though, like not to defend the physicians that like ignore their patients at all. That's not what I mean to say this,
Right.
but there are a lot of patients that will like come in with like these wild complaints. It's like, okay, like come on, it's kind of like you just Googled that and like
Yeah.
told me. Like, you know what I mean? Like there's like a fine line between like, all right, do I trust this patient? And that's I guess where rapport is so important, and having rapport with your patients to know if like this is something serious or something that you think could be serious, you know what I mean?
Yeah, I feel like it's either like pretty obvious if someone is like maybe like amping up maybe their symptoms a little bit, and then obviously there's like patients with like drug seeking behaviors, but I feel like you can kind of like differentiate those patients from others, but I think it also just like comes with time too, which I feel like, I mean, hopefully I feel like our generation that are like going into it are much different than the older generation of doctors that are kind of like retiring out. So hopefully we'll see some changes, but who knows?
Yeah, exactly. Did anyone else have any like thing they wanted to add on how we can sort of reduce these obstacles?
Yeah, like what I don't know if it's something to add. It's just like something like I've noticed with my preceptor going through like family medicine and doing all these screenings and everything. It's hard because we give referrals, we set up appointments and stuff for patients all the time. And then the patient will find out their insurance doesn't cover it or something like that. And then they're not able to do that screening test. And so it's difficult because you put that availability for them, but whether or not they do it too, it like hurts your heart because like you obviously want their insurance to cover it or be able to afford it and everything that comes with just going to that appointment, like transportation and everything. But it's like I don't know, not a catch-22, but it's just I don't know how to counteract like the issues that come with health insurance and covering those screening tests and whatnot.
Yeah, I also recently, that reminds me of a patient we had who just had like all these different issues and like had just like anything that you can imagine. Like if we tried to fix one thing, then something else would pop up and it was like, what's related to what? And once this patient was like stable enough to be discharged, we were like, you know, you need to go like get a kidney biopsy, you need to go see this specialist and this specialist. And we were like, this patient hasn't been to a doctor in years. He doesn't have a very good living situation. So it was kind of like, we don't want to discharge him because we're like, he's probably not going to come back and he might like not make it and go to these appointments. But then it's like, what can you do? You can't just like keep him in there. And then it's just like, you just send him off to rehab and hope that he does his follow-ups and stuff. So that's something, yeah, it's hard because you can't just like have someone to like hold your hand through it, I guess, but they could probably provide, I don't know, I guess there's something that the authors did, which I feel like could kind of help that I thought was interesting, but we'll get into that in a second. Yes, I don't want to mispronounce your name.
Munatiso, that's fine.
Okay.
Yeah, I think a lot of what we're trying to say is like a lot of this is like rooted in like system failures. So I think as much as a lot of us don't like to, I think a lot of this requires getting involved with like advocacy and like politics so that people do have access to transportation and insurance does cover some of these things. So I just wanted to add that to the conversation.
No, that's definitely super important. There are a lot of systemic things that need to change much higher up than what we can do, but you know, yeah, we can just do what we can, but I feel like things are, hopefully we're moving in the right direction. Does anyone else? Oh, sorry.
I definitely wanted to add too, as someone who grew up in a low socioeconomic area, one of the things I've noticed that places are starting to do in my area, and I've been fortunate enough to rotate in a very similar area of New York and Connecticut. They've made all-inclusive kind of areas. So like I'll go to the office I worked in for my family medicine rotation. We had a mammogram down the hall and an x-ray tech. And if we knew somebody had like a low socioeconomic status, we would try to schedule them on the days and they would have these people that would read them and do them 3 days a week. And I think that's something that in the future needs to be incorporated into more offices because that made such a huge difference from people like coming and going. Like we could say, go down the hall right now and get your mammogram. Go get it. And that kind of put the stop in place because during my rotation, I saw 2 or 3 people get diagnosed with cancer, but they hadn't had their mammogram for 5 or 6 years because, oh, I can't get a day off from work or it's a lot of money. If their insurance was accepted, we sent them right down to the hall because then it was covered. There was no backtrack. And I think
No,
that's what we need too.
no, I mean, that's like ideal. I mean, I feel like you should be able to, yeah, no, it makes so much sense. Like, I feel like, okay, you go to your, internist, PCP, and they're like, all right, you need to go get all these screenings. And then it's like, how are you supposed to take all these days off? Because a lot of the time, these people have much bigger things on their mind, like they need to work to, feed their families or to like take care of their kids and things like that. So you can't just be taking all this time off of work. But if you could do like one day where you go in and can get it all done, then it's like at least make it a little bit easier on the patient.
Exactly. And I think that's something in the future, like we do need that advocacy with our own states and with our own like local governments to make sure that Medicare and Medicaid are covering it, because those are the people that fall through the cracks most often, as we've been discussing. But to
Mhm.
see it in action definitely opened my mind a little more to how quickly we can get things done if everything is in one place instead of having to go 14 different places. Like, I don't even want to do that.
No, I get that. No, and that's really cool that you've seen like clinics start being able to do that, because yeah, it would just make sense that that's the way things should be going towards.
Yeah, and kind of like to domino off of what Jordan said, when I don't know if any of you guys have done rotations like in Miami, like your family medicine rotations, but we had a clinic there that was like dedicated to the homeless shelter across the street. So like having things like that in place can also help with even like with incarcerated population, like having something like, I mean, obviously not the technology there to like perform the screening test, but like at least to have like a doctor go in. I don't know how it works with incarcerated patients, to be honest, at all. So like I don't even want to misspeak about it, but to just have some kind of system in place.
Yeah, it was weird. They kind of really like, from what I could understand from what they were saying, it's just like it's state to state dependent on like all their regulations and whatnot. So who knows? But I feel
Right.
like there could at least be like some like nonprofit group or something that could like go in one day to do, I don't know, exams or things like that. But I guess it's like, I don't know. Who knows?
Actually, interesting enough, so I'm in the Danbury Norwalk track for Ross, and we have community clinics for all of the internal medicine residents and OBGYN residents. I believe the family medicine and psych also rotate through them. And then the specialists from within the area donate times. Like Wednesdays is ortho clinic, Thursdays is like
And
the
then-
urology clinic, but the residents themselves run the clinics, which is amazing to see because they're getting the hands-on time. There's a no fee, or it's like a $10 fee, and the states fund it. And I've seen that now in New York and Connecticut. And I think that's something that's residency programs should start going towards, because then patients are getting more care, the
Mhm.
appointments are longer, and there's no cost to them.
Yeah, I mean, that would just make so much sense. That sounds like, I feel like that's a solid move in the right direction.
Just needs to be all of the states and not
I-
just some states.
Yeah, and obviously there are some states that are more willing to put money into healthcare than others, so.
Unfortunately.
But any other things anyone has, comments or things to add? All right, well, we could go into the very last bit. So very, very similar to things that we've mentioned, and then a couple of things that we didn't mention. But the authors so they implemented all of these things within their own safety net system. And so their goals were to increase community demand and access to breast cancer screening. So they used a data-driven strategy to monitor like different breast health metrics in order to assess the barriers that needed to be addressed. So first, they wanted to increase community demand. So very similar to what Sam was saying for On the Island, they provided in-person and virtual education. So they did like webinar series, videos, newsletters, and then like booths at health fairs and different outreach events. And the next, which I feel like could potentially help like with, I feel like a big part is just navigating like these super complex healthcare systems. Like we were saying, you have all these follow-ups and you have to get all these specialists and they're all in different places. So they wanted to create a patient navigation and care coordination program. And so basically these would be like a guide for women as they go through screening, diagnosis, and treatment of breast cancer. And so they often recruited community health workers. And I believe that a lot of these were members of the community, which is super important, especially in some of these populations, because these members are more trusted than other, than like your healthcare provider that's just coming in once in a while, and also usually familiar with local culture and can provide culturally appropriate education, outreach services. They can help patients be advocates for themselves and go through and navigate these systems. Additionally, with transportation and childcare, they were saying that, these community workers or somehow, like try to help with arrangements or vouchers and discounts, working with other companies to try to get transportation services or childcare services for people to be able to make these appointments. And then one of the biggest barriers is loss to follow-up. So one of the biggest groups are those who go through the emergency department as their first line of care. So they mentioned like educating the ED physicians on like the appropriate imaging to order. So then at least like all of those things are done. And then another big barrier is just forgetting your appointment, which I'm sure everyone has done. And so they focused on doing appointment reminders via, phone calls or text messages. And then during these, obviously an opportunity for patients to be able to reschedule appointments during that phone call and not having to like sit through and try to call someone, since it's always like the most like complex thing to just talk to someone in a healthcare office. And then lastly, they had a mobile clinic. So basically they did mammogram services and other screening exams by kind of going into neighborhoods like on the weekends and things, so then it wouldn't take away from work, and then they wouldn't have to travel as far, and then they could get their services that they needed. So those were some of the things that the authors did, and I believe this was actually in Texas. I don't know exactly where, they didn't really say, but somewhere over there, and this is where they implemented, and they said they saw improvements and stuff. So definitely things to like keep in mind, and hopefully try to get, this across all different communities in the US. But basically, that's all I have for you guys. I don't know if there's any last minute things anyone wants to add or any questions.
I had a kind of comment that turns into a question. So I'll ask the question part first. So the authors did these things, and then you said they found improvement. So my question is, were they significant? And the reason I'm like asking this question is because like having done like an EM rotation, I'm sure most of you guys have also done EM rotations at some point if you're M4s. Like I feel like, and honestly, any rotation, not even just EM, like even inpatient stuff like internal medicine and stuff like that, I feel like their main goal is like getting the patient in and out as quick as possible. And especially in EM, they're like, okay, so I did IM first and then I did EM right after, right? And I'm like going through differentials with the attendings and stuff like that. And they're like, all right, well, is that going to kill the patient right now? And I'm like, no. They're like, okay, well, then we don't care about it. So that's kind of like how they think about it. And I'm sure there's anomalies to that, like in any field, but like, that's just my specific experience. But I mean, I'm sure a lot of EDs are similar in that sense because, they need beds. And like, I get it. It makes sense as to why they're trying to like have such a high turnover rate, but it's also just like so frustrating that that's the way it is. And a lot of the times it just default to like, all right, follow up with this specialist or follow up with, this is a family, like a PCP issue that we don't need to deal with like here. And Ananya, you wanted to add something?
Yeah, and like, I mean, Anisha maybe was going to talk about this, but like, I feel like part of the reason we have that issue in emergencies because we as a community misuse emergency services when we really should be going to our primary in the first place. Like how many people come into the ED for like checkups or like for the
Like the
common cold or like
Yeah.
whatever, like when it's just like if you had a primary, they would take care of that for you. But a lot of times if you ask them why they don't do that, it's like an insurance issue. They don't have the money, they don't have the time. And because especially in America, we have this like physician shortage, specifically with primary care. They're like these huge waiting lists just to go see your primary care for like a normal visit, let alone like if you had an emergency, you can't get in.
No, that's so true. No, I agree. I was just trying to look back at the article, Sam, but I can't figure out. I feel like I don't know if it was like statistically significant, but I think they did see like an improvement in screening rates, but I will get back to you and let you know because I feel like they did mention it, but of course now I can't remember.
That's okay. Sorry for putting you on the spot. I was just
Well,
curious.
good. Anyone else, anything that they want to comment or add? So basically, just to kind of conclude things, we, in the US, race, ethnicity, and social determinants of health are huge barriers and can impact breast cancer disparities in underserved women, and implementation of community partnerships, education, outreach activities are some important strategies that, we should try to make more, try to do more for, these populations and try to reduce these barriers. So, and like, as we know, breast cancer is a pretty survivable cancer at this point. So it is kind of, like people shouldn't be dying because they can't get access to care or they're being delayed in treatments and stuff like that. So it's, I feel like a very important topic, especially, for the US. I mean, probably other places, but I think this is something that like really shows how your like socioeconomic status, all of these things can really impact your care that you get here. So yeah, I don't know if anyone else, any questions, anything else to add? Otherwise, thank you.
Yes, thank you, everyone. And thank you, Anisha. That was a great presentation, great discussion there.
And thank you guys for all like participating. It makes things so much easier than just like talking about whatever. And yeah, I appreciate all the comments everyone had. Thank you so much.
Yeah, it's definitely a good topic to get a discussion going too, and it's like something that everyone needs to be aware of. So this was a good talk for today. If there's nothing else, then we'll take a quick, I guess, 5-minute recess and then get back here for the rest of our CRG housekeeping things. Let me just stop recording. And thanks to any non-CRG members who attended today. Let us know your feedback. If there's anything you liked or would have done differently, we'd love to hear from you. And for everyone else, for our members, we'll take a 5-minute break, okay? So we'll see you back at 1:55 p.m. Eastern time.